That is my lecture now. I request all the participants to note that the lecture that you just attended was on neuroplasticity, and you will use the concepts that have been explained in the neuroplasticity in your daily practice. And you may wonder how you will use those concepts. If you were to take some messages from Dr. Shashikala Madam's such a wonderful masterclass on neuroplasticity, I wish that you remember two things: that the concept of sensitive phase and critical phase, particularly the critical phase, should be very clear to you, and through you should be very clear to parents. Because when they start doing therapy, they invariably get disappointed after a month or so, saying that it doesn't work. What they don't see is that what has been prescribed to them is actually not supposed to work at the level of the arms or legs. It is supposed to work at the level of the brain, which remains unseen and unknown to the illiterate. So those who do not know the concept of neuroplasticity do not understand the importance of maintaining activity of various parts of the body in order to encourage new dendritic connections which will establish functioning. So hence the concept of critical period. Sensitive period, as madam said, is the period where things happen with minimal effort, where functions are achieved with minimal effort. Critical period is a period where functioning will still be attained a little with a little more effort, and beyond critical period, much more effort has to be made by the child for the same function to be achieved. If this can be explained to the parents, then trust me, all parents will happily and faithfully do all the therapy that you prescribe them to. With that final note on neuroplasticity, I would like to start my next lecture on a very new topic. I am confident that very few of the participants would have heard of it. And those who have heard of this topic, I hope that for them by the time I finish speaking about it, they would be able to know how to use this knowledge in their daily practice dealing with children having developmental disorders. And the lecture is on what is known as ICF. So what is ICF? This is the full form that is given on your screen. ICF stands for International Classification of Functioning, Disability and Health. These are the three terms which is classified by virtue of this concept known as ICF. Okay, so it's a classification of functioning, disability and health. Now, when I was first introduced to this topic by Dr. Shashikala, she asked me this question: how do you define health? And then, a lot of definitions came in my mind, and they were all common sense definition as I tried to make them. And we realized that all of us think health is absence of disease. And once you know what is ICF, you'll realize how wrong you are when you think health is absence of disease. When you are asked this question, what is disability? Immediately certain images come to your mind, and you assign the term disability to a very specific type of individual whom we label as disabled. After this lecture on ICF, you will realize that that is an entirely erroneous picture we have of disability. So coming back to the ICF concept, International Classification of Functioning, Disability and Health, it is a framework and a classification which describes all facets of human functioning that are affected by any health condition. And when I say any health condition, it can be just 2 days of fever, or it can be a lifetime of cerebral palsy. Any health condition, ICF is applicable. But I have found it particularly useful when it comes to evaluation and management of a child with neurodevelopmental disorder. And that is what I will make you realize by the end of this lecture. As I said, it is a classification system. It's not a measurement tool. It is developed by WHO through a lot of scientific processes. This has come up. Anybody can Google this and you will have huge literature on this concept, but I'm going to summarize all that and tell you the main aspects of ICF. What was the aim behind setting up ICF? It provides a scientific basis for understanding consequences of health condition. It establishes a common language to improve communication. As an individual practitioner, note that ICF, knowing ICF, helps to set goals of therapy in a more specific way. That is the most relevant to all of us. And of course, using ICF helps to compare data across different fields and countries and code the health condition if you're using an electronic database to record your patient's data. Now, broadly speaking, ICF has two parts. So I'm going to describe ICF in two ways. One is it has two parts, and each of that part have components. So henceforth, we will be using the terms parts and components of ICF. What are the two parts of ICF? One part deals with functioning and disability. And the other part of the ICF structure deals with what is known as contextual factors. Under functioning and disability, you have two components: body function and structure. This is one component. Activities and participation. I'll elaborate this. Just understand that there is part one with two components or three components in which activities and participations are separated. Part two has two components: environment and personal factors. What am I saying? Anybody with any health condition have symptoms or difficulties in two broad part areas constituting different components under each part. When I say that I'm a healthy person, according to ICF, all my functioning, body structure, activities, participation are optimum. The environment in which I live is conducive to my functioning, activity and participation. And personally speaking, I am in the pink of health. That means I am able to perform anything in terms of personal factors as well. When all these five components are working, I call myself healthy. So the components of ICF is what you need to identify and understand. As I told you, there are in total 5 components of ICF: body function or structure, activities, participation. These 3 I told you come under part 1, which is functioning and disability. Environmental factors and personal factors come under part 2, that is contextual factors. As I said, when I have some problem with the body function or structure, it leads to some limitation in my activity. For example, when I first started wearing specs, before I wore specs, I started realizing that I'm not able to see things which were at a distance. So my body structure was affected. I had age-related lenticular changes. It led to some limitation in my activity. I could not read signboards when I was driving by car. That was activity limitation. This is what was earlier called as disability. Limitation in activity was known as disability. And because I could not see things in the far, I could not go out driving with my friends. So I could not participate in activities as a group. This is what was earlier known as handicap. So the components of ICF basically decide my health condition, my functioning, whether I have disability or am I handicapped. Now the term handicap is no longer used for all the right reasons. We use the term participation restriction. What does body function mean? It is all the physiologic functions of the body. Body structure is structure or anatomical parts of the body. Activities is execution of a task or action by an individual. Participation is involvement in a life situation, like going to college, teaching, employment, going out for a joyride, anything. All this when done in a group is participation. Environmental factors, all aspects of the external world that impact on the person's functioning. If you have understood what each component means, then it will be easy for you to apply this principle in your patient with a neurodevelopmental disorder. How that can be done, I will give you an example. But to reiterate, body function is all the physiological and psychological function, which include neuromuscular, skeletal system, as in cerebral palsy, movement related functions, vision, hearing, speech. So if you want to identify body function or structural impairments in an individual, these are the headings under which you will label the child as having a body function or structure impairment. Body functioning is not related to cause. When I say that a person has problem in fluency and rhythm of speech functions, it is immaterial of the cause. I don't need to know whether that problem, that rhythm or fluency problem of the speech is because of stuttering or stroke or autism. I don't need to know that. Just the fact that there is a problem in the body function of speech is enough for me to proceed with further interventions without knowing the diagnosis. That is the beauty of ICF. Activities and participation is describing individual's functioning as a whole person, as opposed to function and structure of his body part. Or so what aspects of our life come under activities? They are anything like basic activities like dressing, eating, and bathing. This is activity, what we do as an individual. Then going to work, going to school, and other civic activities is what we do as part of a society. This is known as participation. So activity and participation, both of them are what we do using our entire body, structure and function, where what we do as a single person is activity, what we do as a group, as part of a society is participation. What is most important is there are a range of activities going from basic to complex that describe a person's ability to live independently and be integrated into their communities. Environmental factors are anything related to products that we are using to enhance our life, technology, the natural environment, changes made to the environment, how your staircases are, whether you live in the 4th floor, whether you have an elevator, support and relationships, how many friends I have, how are my family members, attitude of the society, policies, government policies, all of them constitute environmental factors and dictate or regulate the way I live, healthy or disabled. Personal factors have not been defined very well by WHO. Some of the factors that influence the way I live, healthy or disabled, is my age, gender, coping style, motivation level, education level. So these are the different components of ICF. What is disability? As I told you, if there is body function impairment, like loss or abnormality in body structure or function, we call it as impairment. Activity limitation, when there is difficulty in performing certain activities in terms of quantity or quality. Participation restriction, problems an individual may experience while getting involved in daily life situations. We may have environmental facilitators and barriers. So when I say ICF for health, I call it as body function, activities, participation, and contextual factors like environment and personal factors. When I say ICF for disability, I use the terms body impairment, activity limitation, participation restriction, and environmental facilitators and barriers. So this is how an ICF structure looks like. You describe a health condition, any health condition, let's take cerebral palsy. You describe the child's body function or the impairment. So it could be spasticity, tone, body function, tone, muscle tone. That spasticity will lead to activity limitation. So because of that muscle tone, child is not able to walk. So the child has disability. And because the child is not able to walk, the child is not able to go to school. So there is participation restriction. And the child's function, activity, and participation are further aggravated or further facilitated by the way the child lives, his family, the child's environment, financial status, etc., and how the child is. What is the age of the child, gender, personality? All these things are interlinked to each other, and they affect the severity of the condition and how the person's condition can be managed. Just by you writing baclofen to a child with spasticity and sending them home is not going to improve the child's condition unless you identify the activity limitation and do something about it, identify the participation restriction and address it, know the environmental factors which may facilitate and enhance it, or barriers which need to be removed, and know the child's personal factors to help mobilize, to facilitate success of your intervention. And that is why it is very imperative for all healthcare professionals to understand a child, assess a child on this template of ICF. So I'm going to now give you a quick example of how you deal with a child and use ICF, and how that approach will help you in your daily practice. This is a very familiar case scenario. 3-year-old male child of unrelated parents brought with complaint of being unable to walk properly and delayed milestone. All of us here in today's workshop would have at some point or the other managed such a case scenario. We all are trained to take history and do some basic examination. So all this information should be easy for us to elicit. We find that the mother is elderly primary, child was born full term by normal delivery, perinatal history of seizures, then both parents are educated and working. We may not know this information. Mother is keen for a cure so that the child becomes normal. Grandmother is at home taking care of the child with the help of a maid. And child cries excessively when handled by doctors. See, I made it a point to write all these information also, which all of us may or may not take. But you will realize that it is important to know this information from the ICF template of intervention. When we do a basic development assessment, we find that this child has learned to sit at 2 years, walks with finger support and walker, speaks few words, uses assisted pencil grasp in fine motor, has normal hearing, follows command. Mother can understand what he says, but a stranger cannot understand, which means when you talk to the child, you don't understand what the child is saying. Child can take solid foods, is fed by mother. Otherwise, when made to eat on his own, he takes a long time to eat with lot of spillage. Cannot undress but helps mother while wearing shirt. Cannot manipulate buttons, holds pencil with adapted tripod grasp, attempts to scribble on paper. All this information, all of us can take. No, nobody needs any special training. You've already been trained in your undergraduate, postgraduate days. Basic neurologic examination, you find that the child has hypertonia, both lower limbs and left upper limb. DTR is brisk. There is spasticity. MRI is normal. The child tends to walk on toes with a scissor gait, but plays football with the walker and is mostly cheerful. How do I use all this information? Now, there are two ways of using this information. The first way is what we call as a traditional approach that all of us have been doing, and we hope that post idea workshop all of you will not be doing. This approach, the traditional approach, is known as the medical model of health care, where we try to determine the cause, rule out differentials, then refer the child to orthopedician and refer the child to therapist, and counsel the parents that most likely this is a case of cerebral palsy and it cannot be cured because the damage has already occurred when the child was being born. This is what we would do. What are we actually doing is we are using what is known as rule out approach. We try to know why the child is not working. Is it neuromuscular cause? It is orthopedic cause? Is it nutritional cause? We seek opinion from send the patient to different professionals, investigate to rule out differentials. And then once we have all the information, we counsel if the condition is not curable or refer to higher center for management. Now I can tell you that do not use this approach. Even though you know that this is what most of us do, I can give you a better way of approaching this patient. But if you use this approach, what happens to this patient? Invariably, the patient is either lost to follow-up or goes to another doctor who can give them a more positive information, who can give them more promises. Like Madam showed you in the first lecture, the fate of a typical child in our country. Now let's try to use the ICF template for that case history that we have taken. If you take the detailed history and examination, you will realize that when I place the child under the heading of body impairment, I write hypertonia of both lower limb with muscle tightness of tendoachilles, that means contracture, hamstring, hip adductors, and Achilles tendon. The child's activity limitation was understood from the history as inability to walk, inability to independently perform activities of daily living, and because the child is, I think, 3 years old or 4 years old, the child should be writing, but which the child is unable to write, so that becomes an activity limitation. So these are the activities that I identified as limited from the history and examination. I also knew that the child had trouble playing with other children and was not getting educated as any 4-year-old should get in the typical course of life. I also understood that in the environmental factors, there were parents who were anxious and who were looking for a cure. And they were also troubled by the fact that because the child had to be physically carried to the school, it was a great problem to continue child's education. Personal factors were very positive. I found that the child was a very cheerful child and very motivated. How does compartmentalizing my history and examination under these 5 components of ICF help me in managing this child? I know that if I can handle any one of these, if any of these components are in my control or in the parent's control, I can influence those that are not in my control. I know that it is an incurable disease, but does it mean that I can't do anything for this child? Does it mean that parents can't do anything for this child? No. There are a lot of things that can still be done if you look at this ICF components. How it can be done? So basically, this is rule and approach where I have compartmentalized all aspects of child's health condition. And now I know that I can influence lot of things. And how do I do that? By using ICF, I have not worried myself into trying to get a diagnosis. I have shifted the focus from cause to impact because now I am concentrating on individual ICF components of health and functioning. ICF forces us to think about what the child can do from what the child cannot do. It lays emphasis on participation and importance of participation in brain development. It gives a meaningful way of communication with caregivers, a more empowering and positive way of communicating with caregivers. It encourages us as healthcare provider to plan how to optimize child's functioning rather than how to fix it. And it provides multiple points of entry for intervention instead of a vertical hierarchy and referral basis of intervention. Here, even if the child goes first to a therapist instead of to a pediatrician, or even a therapist can start intervention without the need for having actually a neurologist or a pediatrician nearby. The therapist can understand which components they can handle and start interventions till such time that an expert is available for further care of the child. So what are the questions as a clinician which are answered by using ICF? I can understand what is the child's level of functioning or disability. What are the activity participation limitations? What interventions can maximize the functioning? How conducive is the environment for the intervention that I'm planning? What are the family strengths and weaknesses? Can I tailor the intervention based on those strengths? What is the family caregiver's goal? Is it in tune with my goal? The family wants the child to start walking, but my goal is that the child should first learn to sit. So the ICF tells me, gives me an opportunity to use this as communication with the family. How useful are the interventions that are being planned? How can the environment, personal factors, my approach be modified? Do I need to refer? How should I communicate with other health professionals before I refer? All these important questions are answered if you use ICF in daily practice. And once you know what is the body impairment, without knowing the diagnosis, you know that for spasticity, you have to use medications. Even while the medications are working or not working, I can certainly improve walking of the child by use of some assistive devices. So at least the child's participation is not restricted. This way, the child's brain is more neuroplastic and ready to quickly achieve functioning with minimal effort. Environmental factors and personal factors can also be addressed in your list of prescriptions. Now take this case. You all can see that, I mean, this is just a case example to quickly put the child in this ICF template. You have another child who is second degree consanguineous, brought at 4 years of age, referred by a GP as ADHD because he does not sit in class. There were no antenatal or perinatal problems. And family history, there is delayed speech development in the father, but father is now a successful IT engineer. Mother is a software professional. Grandparents are the caregivers. They perform a lot of pujas and pray for the child recovery. Parents want mega vitamin therapy. Child does not mingle with other children, plays alone with cars, mostly can remember a lot of TV ads, but does not speak. Pulls carers towards needs without uttering words, but can sing TV ads. There are no history of regression of milestone, no history of seizures. MRI is normal, BERA is normal. Child is diagnosed as ASD, but it doesn't matter if I know whether the child has ASD or not. What I know is the child's body impairment. What part of the body function is affected? So looking at this history, I know that the child's communication is affected. Child is not able to speak. Because father had late speech development, the child was not considered atypical till about 4 years of age. So I say body impairment is speech and vocal cord functions. Activity limitation is the child is not able to communicate with the caregivers. Participation restriction is not able to play with other children. Environmental factors are that both parents are professionals. They may not be able to give as much time as grandparents, but grandparents are looking for miracles and cures. These are the environmental barriers. And personally, the child has, I can't see any behavioral issues, but it is a 4-year-old child. So amenable to therapy in the critical period for speech development as a function. So when I understand it as a body impairment, activity limitation, and participation restriction, I know exactly what to do for each of the components of this child's health condition. For activity limitation, I start telling the parents to use picture cards, start training the child to use picture cards for communication and other ways, teach them other ways of communication. I know this is body impairment, speech function. There are no medications that I can use, but the child will need therapy from a speech pathologist. Environmental factors, I work on parents and counseling them, work on grandparents to counsel them. So I know a lot of things that I can do once I start using the ICF. So as I said, from this case scenario, the body function impairment that I understand is voice and speech function. The activity limitation is one of these 4. Which one is affected? There is no limitation in mobility, but definitely there is a limitation in communication. And as far as environment is concerned, we find that there are a lot of attitude barriers. Support in relationship is not a barrier, but attitude is a barrier. So I identify these components of the child's health condition. And then what do? I start intervention. How does it help? As I said, body impairment, usually I try medical therapy or surgical therapy and early intervention therapy to prevent contractures as body impairment. For activity limitation, I start goal-based interventions, use assistive devices. To improve participation restriction, I indulge in some community awareness and refer the parents to some websites where they can have more help and empower them with their legal rights and policies from the government schemes. All these things are more focused if I understand the the health condition based on ICF components. So friends, finally, ICF is about human functioning, not merely disability. It is a universal model, not a model based on a concept of disability, which is known as minority model. There are a lot of advantages of shifting from the medical mode of delivering healthcare services to a biopsychosocial model, which is known as on which this ICF is based. This is the broad structure of ICF, where Each component is further classified. Now, Dr. Urmila will share a Google form link in the chat box. If you have understood what are the ICF components, I request you all to read these 4 case scenarios and try to identify which component of ICF is being described from these case scenarios.
I've already shared the link, ma'am.
Yeah, so we will give them about 2 minutes to read the case scenario and quickly click on the options given on the Google form. And I want to remind all of you that this is an essential activity for certification. And this activity cannot, the Google form will not remain open forever. It has to be closed so that we can move on to the next session. So the first case scenario is 15 months old preterm child, history of delayed birth cry, not yet sitting. Mother's complaint is child's thighs cannot be separated to change nappies because they are so tight. So you have to identify which component of ICF is being described here, whether some kind of body impairment or activity limitation or participation restriction, environmental or personal factors. Case scenario 2 is 9 months old child, second of twin, had delayed birth cries, stormy neonatal period, birth weight was 800 grams. Mother says that the child chokes on anything that is not mashed in a mixer, and the child is irritable most of the time. Which ICF components are described here? Third case scenario, 15-month-old preterm, delayed cry at birth, not yet sitting. Mother says that the father does not want to take the child to doctor. And she has trouble bringing the child to the OPD because she is afraid that her husband will scold her for going away from the house and neglecting domestic chores. Which component of ICF is reflected here? In the last case scenario, 3.5 years old child had delayed birth cry, required neonatal intensive care for 45 days. Mother says that the child is not able to walk and is not toilet trained. The Anganwadi workers do not like to keep him in school because of his poor toilet control. This is what I found when I got the history. What ICF components are identified here? So Urmila, if you can tell me whether 2 minutes are up and adequate, all the people have responded, we can close this session. The right answers will be displayed at the end of today's workshop. And with this, I see that only 10 people have responded. I'm going to give another half a minute. And after that, the registration link will close. So I encourage everybody to please finish responding. As I said, response in every session test is important. Don't worry about right or wrong. Please respond and try to respond correctly. Incorrect answers will be explained later on, but the answers cannot be changed. So there are 16 responses and 10 seconds to go. I request Ms. Hamsa Gowda to take up the next lecture, which is on functional classification. and she is a very experienced person, a young person with a rich experience of working with children who are at high risk of developmental disorders. She is a physiotherapist working at District Early Intervention Center at Bangalore Medical College and Research Institute, Vanivilas Hospital. And she's been there for 5 years. And I hope her rich experience will reflect in this very important lecture of GMFCS. With that, I close this link and invite Hamsa to take the screen, share the screen.
Thank you, ma'am. Is my screen visible?
Yes, Hamza.
Yes, Hamza, it's visible.
Okay, thank you, ma'am. Good evening, everybody. Coming to functional classification, which is the third most important concept in our daily practice after ICF and neuroplasticity. The first functional classification, that is gross motor functional classification system, is what I'm going to talk about. Out of all the functional classifications that has come up recently, this is the oldest one. After this session, you will be able to use the gross motor functional classification system, and you should be able to distinguish between the different levels of GMFCS. You'll be able to use, you'll know how to use GMFCS to communicate with parents and prognosticate. At the end, there will be a video quiz you will have to answer so that I get a feedback on how you have, how much you have understood or how well I have explained it to you. What exactly is GMFCS? It is a functional stratification of motor abilities of children with cerebral palsy from 2 to 18 years of age. This classification is based on the self-initiated movements of a child and on usual performance at home and not in our clinic. It tells us about the child's usual routine rather than what they are able to do at their best in ideal condition. And GMFCS concentrates on child's abilities rather than limitations. There are separate criteria available in 4 separate age bands, that is 2 to 4 years, 4 to 6 years, 6 to 12, and 12 to 18 years. 2 to 4 years age band has come up recently. Earlier, GMFCS classification was for age group where the child would have already started walking. It was by observing the gait. First, we will discuss GMFCS for children who are able to walk. There are 5 levels in all the classifications. The first level in GMFCS is, it tells us that the child will be able to do everything that a neurotypical child is able to do. That is, the child will be able to walk both indoors, outdoors, climb up and down the stairs without any limitation. The child will also be able to run and jump, but there will be impairment in speed, balance, and coordination. This is level 1. Level 2, the child will be able to walk both indoors and outdoors, but on challenging surfaces. Challenging surfaces like inclined surface, uneven surface, and in crowded area, child will have some visible difficulty. And the child may need some sort of support, or while climbing up the stairs, it uses the railing support. But still, the child will be able to do all the things independently. Level 3. The child in level 3 needs an assistive mobility device to walk on challenging surfaces and also on level surfaces. To climb the stairs, the child may need railing support and also a little assistance from a caregiver. From level 3 onwards, the child will not be able to do things independently. Child needs an assistive mobility device or a person's assistance sometimes. Level 1 and 2, child will be able to do things independently. From level 3, it needs support. In level 4, the child not only needs an assistive mobility device, but also a caregiver's help to support the child to maintain a posture. They may also require a wheelchair with assistance of a caregiver. So difference between level 3 and 4 is that a level 3 child can move around with the help of an assistive mobility device without the help of a caregiver. But in level 4, it requires assistive mobility devices to maintain the posture and also a caregiver to provide additional support. So level 3 and 4 is the amount of support that the child needs. And level 1 and 2, child will do, in level 1, the child will be able to do everything independently on challenging surfaces also. There will be only impairment in speed, balance, and coordination. In level 2, the child will have difficulty on challenging surfaces. Level 5, the child cannot maintain anti-gravity position. So the child has to be carried manually. These pictures provided by CanChild. This is the pictorial depiction of what I have explained to you so far. Here you can see in level 1, child can do all the things independently, but there will be impaired speed, balance, and coordination, which will be seen after 6 years of age. In level 2, the child will have difficulty on challenging surfaces, but still it will be able to do all the things independently with some sort of support like railings to climb the stairs without assistive mobility device or caregiver. In level 3, the child may need some support to maintain anti-gravity posture. It needs assistive mobility device to walk both indoors and outdoors. As I said, difference between level 3 and 4 is the amount of support that they require to maintain anti-gravity posture. In level 4, the child needs assistive mobility device and a caregiver support. Level 5, the child cannot maintain anti-gravity posture. How do we assign GMFCS levels to a child who is not walking? Because the child will be brought to our clinic when they notice delay in neck holding or delay in sitting. So that doesn't mean we don't classify, we don't give GMFCS levels. So the first one is rolling. Child in level 1 and 2 will have normal rolling. What is normal rolling? It is the sequential movement of neck, trunk, and hip movement. So in level 1 and 2, there'll be the sequential movement of all these three. That is normal rolling will be present. In level 3, child will have deviant rolling. The sequential rolling will not be present, but still the child will be able to roll without any assistance. In level 4, there is log roll. Log roll as in all three parts, that is neck, trunk, and hip, will be moved together to go into the prone position, and they may need assistance to change the posture. And but spasticity will be present in all the 3 levels. I mean in all the 5 levels. In level 5, the child cannot hold anti-gravity posture. Next, coming to sitting. In level 1, there will be delay in attaining sitting. The child may sit by the age of 1 year or 12 to 18 months, but still the child will be able to sit without hand support. It can use its hands to manipulate with toys. In level 2, child will be able to sit on the floor with legs crossed, but it needs some hand support. Level 3, the child will have W sitting, and it can it does not uses its hands for support, it uses to play. In level 4, the child sits only when made to sit, and the child may also need truncal support. Level 5, the child cannot sit. Next, coming to crawling and standing. Crawling, in level 1, there will be delayed in attaining crawling. The child may attain crawling by between 18 to 24 months, but the reciprocal action will be present. In level 2, there will be again significantly delayed in attaining crawling. The child could have attained crawling by about 24 months, and reciprocal action will also be present. In level 3, the child will have commando crawling. That means there will be no reciprocal action. In level 4, the child will not move forward in prone, but log rolls all around the house to move. Level 5 cannot crawl. Next, standing. There will be delayed in standing, but the child will achieve it independently. And in level 2, the child will able to pulls to stand only on stable surfaces. Level 3, standing will be delayed significantly. That is, the child may attain standing after 4 years of age, and it might sometime achieve it even without support. In level 4, the child needs adaptive equipment to stand. Level 5 cannot stand. These are the things that we have to remember in our daily clinical practice. That gross motor functional classification system is not always an indicator of severity, because 2 children with cerebral palsy of GMFCS level 4 may not be of the same severity. The severity of CP also depends upon the comorbidities like SPCCBM. It is an acronym for sensation, perception, communication, cognition, behavior, epilepsy, and musculoskeletal system that is involved. If a child with level 3 has uncontrolled seizures and a child with level 4 has no seizures, then this means that the level 3 child will be more severely involved than level 4 child. GMFCS is not recommended to apply before 2 years of age. If at all we are doing it, then we'll have to reclassify it again at the age of 2 years or after 6 months of initial classification. Our interventions does not change the levels, and it changes in less than 10% of cases. And does it mean that we don't work because we don't work with the child because we don't change the levels? No, because our aim is not to change the levels, but to improve the functionality, participation, and thus the quality of life of the child along with its family. So we work on improving the quality of life of a child and also their family, and hence we are helping the child to improve its functionality and participation. So how do we do this? By giving play-based interventions, providing orthotics to prevent contractures, and also assistive mobility devices. This all can be given at an earlier stage so that we prevent the further contractures and other complications. And it is also not a diagnostic tool. GMFCS level stabilizes by 6 years because the gross motor development reaches its peak by 6 years and it remains true lifelong. GMFCS helps us to prognosticate and to answer most important and common questions that every parent of a child with cerebral palsy asks us. Will my child walk? Or when will my child walk? So if a level 1 child sits by 1 year, then we can say that the child will walk by 2 years. And if a level 2 child sits by 2 years, we can say that the child will walk by 4 years. a level 3 child, if he sits by 4 years without support, he will walk with help of assistive mobility device by 8 years. If a level 4 child sits with some back support by 4 years, then he will walk with frame indoors. And level 5 child cannot sit or walk, but will advise on environmental modification and devices, so that the child enjoys his, the child will actively participate in playing and all that. And all this will happen only if the child undergoes regular intervention. How do we distinguish the levels? We ask the parent that if the child can walk independently and climb the stairs. If the answer is yes, then the child will go into level 1 or 2. And if the answer is no, it will be level 3 or 4. How do we distinguish between 1 and 2? We'll ask them if the child is able to walk on uneven surfaces and climb stairs. If the parents say yes, then it is level 1. If the parents say that it requires some support, then the answer will, then the child will goes to level 2. And how do we distinguish between level 3 and 4? If the child does not walk independently, we ask them if the child requires any assistance for walking or climbing stairs. If the parents say yes, if the child is able to manage with handheld mobility devices, then the child goes to level 3. If the parents say that the child needs personal assistance, then the child goes to level 4. And level 5 has to be transported manually or by wheelchairs. So now coming to the last part, that is the video quiz. Video will be played and a link will be shared with you in your chat box. You will be given 1 minute after each video for you to answer. You'll have to just answer and wait until we complete all the 5 videos, and then you'll have to submit it. Please remember that you will have to submit it before 1 minute, and if not done, then your certification score will be taken away. And the video will also be not replayed. So please observe carefully.
I also request everybody to open the GMFCS algorithm in their manuals so that they can quickly identify this child's GMFCS levels. Once she starts playing the video, please look at the video, and then at the end of it, you'll get 1 minute to assign the level. Please see and identify what GMFCS level this child has. You can all see that the child is walking with the help of a rollator. There is no person assisting this child. You have to decide whether it is GMFCS 1 or 2 or 3 or 4 or even 5. Please respond in the Google form link.
Three.
No, you have to respond in the Google form because the form will get submitted and your answers will be recorded and collected by us. Hamsa, can we have the next video?
Yes, ma'am.
You have to see whether the child is using any assistive device, how stable the child is, what is the balance and coordination, whether somebody is helping the child in walking, and assign the GMFCS level.
And also on what surface the child is walking.
Yes. Next video. Please decide whether this is GMFCS 1, 2, 3, 4, or 5. I request everybody not to answer in the chat box, but to answer in the registration form given to you individually.
I cannot see any responses in the Google form for the first video also. Everybody is typing here. So everybody is gonna get 0 marks in this quiz.
Everyone is requested to understand the instruction very clearly. There is a link given in the chat box. Please click on the link. A Google form will open in your respective systems. Once the Google form opens, there will be questions related to this video. Click on the right option. It's very easy. Please follow this format throughout the workshop, because that is the way we have planned this session feedback, each session. Is that the last video, Amsa?
One more.
Please see this last video, because the videos will not be played again. You have to, this is the 4th video currently. This is the 4th video. See how the child is climbing up and down the stairs, whether it is stable, holding on to the railing, whether a person is required. All these things you have to identify and accordingly assign GMFCS level, requesting both these people who are answering in the chat box to not answer in the chat box, but use the Google registration form to answer. Urmila, how many have answered?
0 responses.
Is there any problem? Somebody can explain, is there any problem in accessing? Mr. Abhay Singh, can you explain whether it is Google form has mandatory 7 responses?
Yes, madam. Actually, we will have to take all the responses, and finally, when we submit, probably
Wait,
then
we will just edit that mandatory 7 responses. Urmila, can you edit that so that everybody can submit?
Okay. So I need to remove the 5th, 6th, and 7th one, ma'am.
No, there will be.
Yeah, 4 videos are played now.
Yes.
So I'll remove the mandatory thing for 5th, 6th, and 7th.
Yes,
I'll remove
yes.
that, ma'am. Yeah.
Yes. Amsa, there are only 4 videos, no?
And this is the last one, 5 videos.
5 videos. Okay.
Okay.
Everybody look at the 5th video, but Urmila remove the mandatory need.
Yes, for
submission.
6th and 7th, I've removed, ma'am.
Yeah.
Okay, this is the 5th video.
5th video. Play it, please. All of you have to concentrate on whether she's wearing any assistive device to maintain posture, whether she's requiring personal support, whether she's maintaining anti-gravity posture at all, and assign the level. So this was the 5th video.
Yes.
I hope everybody is now able to submit the Google form. We will give you an extra minute. Thank you. So you have another slide, or you can?
No, ma'am. No. Fine. I'll stop sharing.
Please invite the next speaker. Okay.
Yes.
Urmila, can you address these problems people are submitting on the chat box about the Google form?
No, ma'am. There is no problem.
Kirti
14 people have submitted, ma'am. 15 people are submitting, ma'am.
Okay. Give them time.
Yeah.
Meanwhile, the next speaker can get ready. Kirti is saying that it is still showing 6th and 7th are required.
Ma'am, I've removed the 6th and 7th one. So there are only 5 questions now.
Kirti, are you able to submit now?
No, ma'am. It is showing that 6 and 7. So again, I have to open the form, that Google form.
Achha. Okay.
Maybe I do like this. I remove this one and again open the form.
Okay. Please try. We'll give you time. Shushti is saying that you have to
Next.
get out, click the same link, and then it will work. So Hamsa, you can
Yes, ma'am.
just say what was the verbally, what was the first video? The child was walking with a rollator on even surface.
On even
Without any
surface.
personal support, isn't it?
Yes, yes, ma'am.
Second video was?
Second video was the child. One.
Child was running across from the mother's side towards the camera.
Yes, ma'am. On even surface, there was impaired balance and coordination.
Yes.
Yes.
There was no assistive device or rollator.
Okay, ma'am. I'll tell the answer now.
No, not now. Not now.
Okay.
We'll tell in the end. Third video was?
Third video was the father was supporting the child with the rollator, who was walking with the rollator, and he was wearing an orthotic also.
But ma'am, the Google form was not 6th and 7th was there in my form. It was not removed.
No, it will not be removed, but you can still submit without answering 6th or 7th.
It is not submitting, ma'am.
So you close that form and again click on the link.
Okay.
Yeah. So that was the
third video.
Third video. Fourth video was?
Fourth video, the child who was climbing up and down the stairs without the railing support.
Without railing support, yes.
Yeah.
And fifth video was?
Fifth one, who was sitting.
The child was sitting.
And the parents were supporting her at the neck and trunk.
Yeah. Okay. Right. So I hope this is good enough time for everybody to recall the videos and assign their GMFCS. And Urmila, are they able to submit now?
Yes, ma'am. 23 people have responded.
So there are still 20 more to respond. Please, we can only give you 1 more minute now. If anybody is having a problem, let us know. Nikita, are you having a problem? Okay, can we start? Hamsa, would you like to invite the next speaker?
Yes, ma'am. Next lecture will be on manual ability classification system, will be by Dr. Vimochana ma'am, who was our pediatrician and one of the important members who was the reason for starting of District Early Intervention Center in Bangalore Medical College. Over to you, ma'am.
Thank you, Hamsa. I'm very glad that you're inviting me, and I'm grateful to all the organizers for giving me an opportunity to be here. So I've asked Urmila to share the screen because I have issues with my sharing. So manual ability classification system, that is MACS. This is the topic that I will be dealing with today. And this manual ability is the working with the hands to do daily activities. So the learning objectives are to understand the term manual ability, evaluate and classify hand functions in children with developmental differences, grade the severity of manual ability dysfunction, and familiarize with tools and activities used for improving the hand activities in children with cerebral palsy. So next slide, Urmila. Am I heard? Urmila, next slide.
Yeah.
Yes, ma'am.
Yeah.
Next. So as already stated, manual ability is performance of the hands. That is the upper limb performance. And this is in daily activities. So this is singularly linked to intelligence and communication skills. Hand activities are complex tasks. See, it is influenced by many factors, like it could be sensory motor, then postural coordination, motivation, so many such factors. But when we are doing the max classification, we would not consider these underlying factors. What we consider is how the hands are used and how accurately or quickly the speed and accuracy with which the child can do the daily living activities like eating, washing, bathing, wearing clothes, buttoning, such things, writing for schoolwork. And play is the most important thing in a child. So where you need everything, manipulating the objects, all these are important for daily activities also and in play also. So these functions are assessed in the max classification. Next slide. So as already stated, every of the functional classification has 5 levels, almost like it is 1 and 2 are almost okay, the child can do it. From 3, there are issues, and 4 and 5. So the child's self-initiated ability to handle objects, because here, like I said, speed, accuracy, how they initiate the activity, how they complete the activity, whether they can do the completion of the activity or not, with both hands in the activity is what is assessed in max. And so suppose they cannot do the activity independently, can they do it with some adaptation, either in the environment or in the object that they're using? That would be assessed. And while using max, we do not do a test. So this is basically done through asking the parents, because see, when the child comes into our center, it happens with any child for that matter, but here more so, the child may not be able to perform the activity because of various other factors. So what we ask the parents or teachers or caretakers, if the child can talk and communicate, the child himself or herself, what activities she can do, what difficulties they are seeing in the performance of the eating part of it, or the wearing clothes part of it, and what adaptations the parents themselves have already done for the child to do the activity. So here we look for the most usual performances rather than the best abilities. We do not look into the best abilities. And like I already said, we don't have assessment scales, these tests that are quite used for many of the assessments. No, we don't have such thing for max. Next slide, please. So level 1, the child can almost do everything that any other child would do, can handle objects easily and successfully. And whatever mild limitation that the child may have would not restrict his or her independence in his activities. Next one. Next slide. So the difference between level 1 and level 2 is that here also the child can perform the complete activity, but the speed may be reduced. Means the child may require a little more time to write or a little more time to dress himself than as a level 1 child. Or the accuracy may not be there. In the writing, it wouldn't be that it is not understood. The writing would be understood, but maybe it's not very, very correct or accurate in those terms of what we assess as level 1. And certain activities may be avoided like once they realize that they cannot do in a particular thing, they may do it, you know, in a little slower way. They may require a little more time to complete their assignment. And manual abilities do not usually restrict independence. Again, here also, like I said, level 1 and level 2, there is no restriction of the ability to do their daily tasks on their own. Next slide, please. In level 3, the child can still handle the object, but with difficulty, with some modifications that may be done. Like say, in the case of a pencil, if they cannot hold a pencil grip may be used. Or if while feeding, the spoon, maybe the handle would be a little stouter. And here the child's, you know, the mother is sort of, if, I don't know if it can be well seen, but at the wrist she is holding so that the child can manipulate the hand and perform the task. So again, the speed is reduced, but between 2 and 3, what happens is there is a limited success regarding quality and quantity, but still the child will be able to complete the task that he or she has set out to do it. Next slide, please. In level 4, it is a little difficult for the child to complete the activity. So may initiate, like here you see the child is trying to you know, reach out to the ball, taking it, but still may not be able to hold on properly, and least of all throwing the ball, may not be able to do the throwing of the ball, cannot even completely hold the ball in the way it is to be held. So they can perform part of the activity with effort, and you can see the child is reaching out, the mother or the caretaker or the therapist is also reaching out and performs parts of activity with effort. Greater effort has been put in, and continue the thing also, they will further try to make the child hold the ball well. And with this continuous support and assistance or an adapted equipment, they may do the activity, but still may not be able to complete the whole throwing of the ball. Next slide, please. In level 5, they cannot handle objects, and there is severely limited ability to perform even the simple actions. So they would require total assistance. Okay, so this is in gross about the 5 levels. So now like we said, eating, writing, dressing, all these are the daily activities. No, if we go, as we have already stated, level 1 and 2, with a little extra time, they may be able to do it. So in level 1, as far as example of roti, they can easily tear the roti, take it to the mouth, and feed themselves. So here it is, this is the hand activity in eating that is being assessed. So they themselves can do it. In level 2, maybe they take a little more time to tear the roti, and while going to the mouth, there may be a little awkwardness. It may, you know, maybe a little overshoot. Then they come back and feed themselves. Level 3, it is even you know, complete coordination in going into the mouth. So there may be a little, like I already said, if it's the spoon handle may be a little modified, or the mother breaks the roti and puts it into the plate, or if it's like our rice, we make morsels of food and keep it. In level 4, they reach out, they take it, but then by the time they take it to the mouth, it may spill out. Level 5, totally dependent that the parent has to feed. Similarly for dressing, no difficulty in dressing or undressing as per the age, that is level 1. In level 2, may do it slowly and a little awkwardly, may not be able to button their thing, or even with a little more time and effort, they may be able to button, but level 3 cannot have button clothes. So then we have to modify. We must realize that this child is a level 3 child. We need to modify the clothes, don't use the buttons, and remove the elastic pant or skirt. And with shirts, like I already said, so we preferably do not have buttoned one. And in level 4, they cannot dress, they may undress. So the undressing activity is a simpler activity than the dressing activity. So especially if you put the elastic pants or skirt. But even then, they can go halfway, not completely do it. Level 5, totally dependent. While playing, we already told about the ball. So we know that throwing and catching, even when we are assessing development, that's how we do, whether the child can throw the ball, catch the ball as per the age. In level 2, they still can do it, but awkwardly the child may be able to catch the ball. In level 3, can throw the ball, but difficulty with catching. In level 4, they cannot throw the ball, maybe be able to just push the ball. And in level 5, they are totally dependent. School work, as far as writing is concerned, no difficulty in holding the pencil, and they can write comfortably also. Level 2 may be slow in writing, the handwriting may be a little, crooked. 3, there may be a difficulty in holding on to the pen. They may, so in level 2 also a little difficulty may be there, but still with that modified posture of holding the pen, they will be able to write. Here you may need pencil grips. In level 4, they can't do with pencils or pen. So computer, it is just the tapping. So that's what they would use. Level 5, they would not be able to write. So in level 4 also they need a writer. Level 5, they're absolutely dependent. Next slide, please. So when a child comes to us and we are assessing and we ask the parents, does the child handle most objects independently? Can he do all his daily activities independently? If it is yes, then just look into what is the speed and accuracy of the job that is done. If it is normal, it is level 1. If there is a difference in speed and accuracy, some minor difference with speed and accuracy, we assign level 2. So if they say, no, he can't do it independently, then we ask whether the child performs a number of manual tasks where modification of the environment is needed, or with a little help from the caregiver, is he able to do the daily living activity? If they say yes, goes towards level 3, where he can handle objects with difficulty and with some preparation. So they may have made certain modifications in the objects in their home environment or the school environment. If no, we then ask whether they can perform or initiate some simple task with support. If they can do it, and they can do partially also, or they can initiate an action, it becomes level 4. If they are not able to initiate the action also, then it becomes level 5. I hope to some extent it is understood. So basically, whether they can do it or they can't do it, that middle part is level 3, and then level 4 still they can do something. Level 5 they cannot do. Yeah, next is videos, I guess. Can you play the videos?
So now is quiz time. All of you, the link has been given to you in the chat box. Open the Google form. As you see each video, please assign the max level based on this algorithm that is there and what Dr. Vimochana has explained. Urmila, are you going to play the video?
Yeah, I think so.
Form is not available. No, please don't open the old link. Dr. Urmila has posted a new link.
Ma'am, I'm not able to find the PPT with the videos embedded.
Urmila,
So-
you had shared one Google Drive with videos, no? The 4 videos. You only had shared it.
So what we can do is, while Urmila searches for the videos, we'll have the last session of the day today, and then we can show the videos. So Urmila gets more time. And Urmila also note that many people are saying that the link is not available. So you can repost the
Ma'am,
link.
the link I have disabled. I was to enable it once the speaker announces that now the videos are being shown. Because otherwise the people will respond without the lecture is over. So then the responses will be wrong. So I will enable it once the video, I find the videos.
So post it only when it is ready to be enabled.
Okay. Thank you so much for the opportunity, because I've come back here, and I hope you could understand. I know it's too much of information, but yes, as we keep doing it, we will realize all the functional classifications. Thank you. And if you
Ma'am, I
will
found the
excuse me,
videos.
I will. No, can I leave, because I have one. It was this IAP Karnataka.
Thank you, Dr.
webinar was just
Vibhusna, for a
decided.
wonderful lecture. I will take over from there. Don't worry.
Can I thank you so much, Dr. Meenakshi?
Yeah, thank you. Thank
Yeah.
you.
Thank you.
So participants, please open the registration form link and look at the video. Don't I concentrate on the important questions that are given to assign manual ability classification system. You have to see whether the task is completed and whether it is done with sufficient speed and accuracy. To decide whether, first question was whether it is being done independently. If the answer is yes, it is 1 or 2. So now you people please answer what this video level would be. Once the video is over, we will go to the next video. Please do not answer in the chat box. I am repeatedly giving instructions. Answer only in the registration form. If you have a problem opening the registration form, please let us know. Urmila, can we go to the next video, please? Can you please share the link again and go to the next video? This is
Ma'am, can I share?
yeah, please do that. You have all the videos with you?
Yes.
Please do that.
But
Urmila, Priyanka is sharing, okay?
Ma'am, I need to be a co-host to share.
Urmila, what is the plan? Dr. Urmila?
I have made Priyanka co-host.
Okay. First video is already seen. Go to the second video.
This is the second video, ma'am.
Okay, please concentrate whether it is being done independently, and if yes, whether the efficiency and speed is correct, is typical.
I'll go with the third one.
Third video, yeah. You have to say if the child is initiating action independently, completing it without help. You have to see.
And next one is just a picture. You have to answer the level.
You have to see the level of support child is requiring to handle that computer.
Okay, ma'am. That's all
Yeah.
with the videos.
Thank you. So why, Urmila, are everybody able to submit the forms?
Yes, ma'am, they are submitting.
Shivangi wanted the link again. Shivangi and Rekha.
Yes, ma'am. Can you please have the link again on the chat box?
Urmila, please post the link. So while everybody is answering, I would like to just summarize what you have seen so far. Manual ability classification system is classifying individuals' abilities based on their hand function. And broadly speaking, as in GMFCS, up till level 3, the person is able to perform independently. Level 4 and 5, the person requires assistance. Level 3, the person requires assistance in the form of additional modifications like orthotics and assistive devices. But level 4, in addition to orthotics and assistive devices, the individual will require a caregiver support. And level 5 will not be able to perform at all. So this is the broad theme for both the functional classifications. Even if you don't remember each and every detail, if you remember this much, I think it will help you to assign the level. So I think we can safely give 1 minute now for everybody to submit. Dr. Urmila, please let me know when I can begin my next lecture, okay?
"26 people have responded, ma'am.
That's okay. Let's go to the next lecture. Urmila?
Okay, ma'am. Next lecture is by Dr. Meenakshi on IDEA 6-axis diagnosis. Yeah. Meenakshi ma'am?
What happened?
We are not able to hear you, ma'am.
Okay, I will start sharing again. Just give me a minute, I'm sharing again. So as I was saying, that what you have listened to so far
Remove allergen.
classifications, GMFC has told you how to assign the severity of gross motor function, not severity, how to assign gross motor function classification, so that it may help you to prognosticate the walking ability of a child, how independent or dependent the child is going to be. As Hamsa said, that even if a child comes at 2 years and has still not started walking, but based on the other gross motor abilities, you assign a level 2 to the child, and the parents ask you, will my child walk? You know that level 2 children can walk. Even level 4 children can walk. And you know that from level 3 onwards, we need to start looking for assistive devices very early and not just depend on physiotherapy alone to make the child walk. So all this information is easy to communicate and incorporate once you know how to assign GMFCS level. You know that when you assign max level, it becomes easy for us to explain to the parents how far the child can go in terms of independence of hand activities, how early we should introduce adaptive devices for the child. So these are some things which become clarified once you assign these functional classifications. There are more functional classifications coming tomorrow, but these two, ICF and neuroplasticity, will help you to understand the current lecture that I'm going to give you, which is the IDEA approach. As was told to you right in the beginning, IDEA full form is Identification of Developmental Differences and Early Action, IDDEA. We have to identify the developmental difference. There is no question of diagnosis here. Once we identify the development difference on the basis of the ICF template, we identify the different disabilities. Then we also know what actions to be taken based on the different components of functioning and disability. Using all this information and a bit more additional examination, we have what is known as the IDEA approach. So what exactly is this IDEA approach? In a very typical utopian world, and I can say that even America is not utopian when it comes to managing children with developmental differences. They also have their problems, but in a very disciplined society, babies are babies with developmental concerns are picked up during regular surveillance. When we as healthcare professionals ask concerns about development from the parent, we do a developmental history and observation in the clinic. We identify risk factors by past history and we document our findings. So all children born in this country must go through this surveillance wherever they are, with whatever doctors they reach. They must go through this surveillance. In addition, according to American Academy of Pediatrics, all children at specified ages like 9 months, 18 months, 24 or 30 months, they must undergo screening. And those who have who have developmental concerns on surveillance should also undergo screening. And once they have been subjected to a screening, then a multidisciplinary team of health professionals evaluate the child, and then the interventions start. This is a typical developmental care continuum. But the reality is that our children do not follow this path, and hence the need for a idea approach, where right at the moment when we have a developmental concern, ideally we should be referring for a structured screening. But if we do not have this facility nearby, then at the least we can do in that child who may or may not come back for follow-up is to use the idea approach and start intervention so that the child may not be lost to follow-up. This is the idea approach. Idea approach involves 5 steps, making what is known, what we call as a 6-axis diagnosis. Here the diagnosis, the word diagnosis is not used in the traditional sense. And the 6-axis diagnosis is used, remembered by the acronym A, B, C, D, E, F. After we have made the 6-axis diagnosis, then we communicate. Then we, based on communication and caregiver understanding, we set goals for therapy and intervention, and also give some early action tips to be performed at home. Remember that we are assuming that we do not have experts. We are not experts, but that doesn't mean that we do not do anything for the child. We provide appropriate referrals to the experts, but we at least perform the first 4 steps before we refer them. This is idea approach. And this 6-axis diagnosis, A stands for anatomic or topographic, like whether it is, I'll tell you what each of them means. B stands for behavioral diagnosis and identifying the comorbidity. Then understanding, having some, if there are some diagnostic investigations like MRI, using that information. Knowing what is the possible etiology through perinatal history, past history, antenatal history, and assigning the functional classification. All these 6 types of information we must have when we write the diagnosis. So this is a far cry from writing just GDD and leaving the child. When you write the diagnosis, you have to include words which represent each of these 6 domains of a so-called diagnosis of a child who have developmental concerns. This is what you do with all the information that you have collected by your history examination. You make the 6-axis diagnosis. On the left side of this card, this is the first page of the idea card that you are expected to start using on at least 2 children after this workshop. On the left side, you have the ICF components, body impairment. You can use the most prominent body impairment. The child may have more than one impairment in the body. Child may have spasticity. Child may also have visual impairment. So any body function impairment whatever is the most prominent, you have to write under structure. If there is a hydrocephalus ventriculomegaly, that becomes a body structure. If there is tone abnormalities, neuromuscular abnormality, that becomes body function. Then you have to identify the activity for that age which the child is unable to do because of that body function impairment. And because of that activity limitation, you have to identify which most important social activity the child is not able to do and should ideally be doing if it was a neurotypical child. Then you have to identify the contextual factors, how the child is, what is the age, what is the gender, the other things that I told you, and what are the environmental barriers and facilitators. So these ICF components have to be completed on the left side of this idea card. This has already been described to you, and you have to start using it. Once you fill this, we will tell you tomorrow how to use this information that you have compartmentalized from your history and examination. Your examination and observation will also give you the 6-axis diagnosis that is mentioned here. And we have already covered 2 of the 5 functional classifications that needs to be filled here. Out of this, we have covered GMFCS level and max level. So this is the first page of the idea card. The second page components will be shown to you tomorrow. Actually, it involves communication and early action using non-technological methods. The clues are given in the second page. Now, the 6-axis diagram, we've covered functional classification part of it, and we've covered ICF. I'm going to elaborate on 6-axis diagnosis in this idea approach. Out of this 5-step approach, the first I said is making a 6-axis diagnosis, on which first axis is the anatomical. What does it mean? A very simple basic neurological examination which all of us should be able to do. Now, I understand that when we say neurological examination, even the best of the clinician avoids doing this because of various reasons. One is because of probably lack of skill in doing a thorough neurologic examination. The other is people feel that it takes a lot of time, and there are 50 more patients waiting outside. So I might as well refer to a neurologist. That is not necessary for children with neurodevelopmental disorder. The least you should be able to do is just assess the tone and the deep tendon jerks. Based on this, you can do a lot of things in terms of assessment and intervention. You have to just decide whether the body tone, child's peripheral tone is high or low, hypotonia or hypertonia, and whether it is on one side or both sides are affected. That's all you need to know when you do a neurologic examination. Second is behavioral problems, axis 2. And in behavioral problems, you need to see these children with cerebral palsy can also have attention deficit, can also be autistic, can also have issues of hyperactivity. So you need to identify these in the way that we try and identify these in even any neurotypical child. Whether the child has excessive stranger anxiety, whether how is the parent responding to the child, whether there is a unidirectional or bidirectional response, because all of this is going to impact the therapy that you're going to advise. And joint attention pointing, whether they are present. In axis 3, you have to identify comorbidities. I already told you it has to be remembered as SP, CC, BEM, out of which perception is very difficult to do, so ignore this. At least see whether the child has visual impairment and hearing impairment. Cognition, whether the child is able to understand as appropriate for age. Communication, you can identify by using a functional classification for communication, which will be covered tomorrow. Behavior has already been identified as axis 2. Epilepsy, you have to note down under axis 3, and you have to look at any musculoskeletal contractures and label it as comorbidity. And O I have added here because in this age group that we are addressing, we are also very concerned about the common medical condition that all growing children have, like constipation, like malnutrition. All this is going to impact the overall severity of the condition. So assigning comorbidities is important as axis 3. Axis 4 is if there are any diagnostic investigation available, there might be a genetic report available, there might be an MRI available, or an X-ray showing hip dislocation in a child with spastic CP. So any of this, please write down the information as axis 4. Axis 5 is etiology based on past history, detailed general examination. You know what could be the possible etiology. Remember, the most common etiologic factors identified in our country for neurodevelopmental disorders are genetic conditions, prenatal infections, prematurity, low birth weight, perinatal asphyxia, postnatal trauma, infection. So these are some things that we need to identify, because these would be some of the important aspects to cover during counseling session when the parents are concerned about whether their next child will also be like this. So this part of diagnosis is etiological diagnosis should also be mentioned as axis 5. And the last axis is already what you will be trained to do, which is functional classification, assigning the GMFCS max level. The other 3 classifications, which are also important, will be covered tomorrow. So this is 6-axis diagnosis. So the first step of IDEA approach is to do a 6-axis A, B, C, D, E, F. And how do you do that? By your traditional history taking, basic clinical examination, and using functional classification. That completes your ABCDF. It is not anything extra. The IDEA module does not require you to do anything more than you are supposed to do for any child with neurodevelopmental disorder. Once you have all this information, then you document in the IDEA card the way I told you. So you write all this in the requisite columns and rows. And once you have all this information, you are ready to counsel the parents. Without all this information, counseling can be highly inadequate. And trust me, the IDEA card will ensure, if you use the IDEA card, it will ensure that you have all the information, and whatever you forget, you will go back and get it so that the IDEA card is complete. Once you have complete information, it will be easy to initiate intervention at any of this level from E1 to E8. All these interventions will be covered tomorrow at your level without being an expert, whatever your profession. As long as you are seeing a child with neurodevelopmental disorder, you should be able to start this intervention using this checklist and using these stick figures, which are so easy to understand, but which will be covered in detail tomorrow. So quickly, how to use the IDEA card in a case scenario. We have Master V, and this is all the history we have. This child is 6 years old, brought with complaints of not able to walk and difficulty in scholastic performance. He is the second born male child of second degree consanguineous couple. Antenatal history was uneventful. He was delivered in a nursing home and cried immediately after birth. Weight was 3.1 kg. Postnatal event was also uneventful. So slowly we are getting to understand what could be the etiology by this history. There is no history of hospitalization, but the child has visited many doctors for delay in achieving milestones, and they have been doctor shopping. Family history: child was brought by mother and father to the OPD. They are a nuclear family. Mother is studied till 12th, and she has accepted the child's condition and is positive about doing anything possible for the child. Father is also a highly qualified person, is gainfully employed, and the child has one elder sister who is neurotypical and who's very playful with the pro band. The child attends a school which is a kilometer away, but has to go by auto, and studies in first standard, but is struggling to understand the whatever lessons are being taught, especially with writing abilities, and gets bullied in school and teased and stared by other children. All this information will not be available to you unless you think that they are important. And once you know ICF, you will know that everything is important for overall management and intervention in the child. So you do a basic examination, you have anthropometry, and you look at some basic general examination points. You identify contractures at knee and ankle. You do a basic neurologic examination. You find that the child has hypertonia, which is involving both sides of the body. So it is involving left and right lower limb, and upper limb only left, but then this will also classify as bilateral spastic CP. The reflexes are exaggerated, and the child has a gait with severe crouching gait. In developmental assessment, we identify the different GMFCS and max levels and other functional levels that will be covered tomorrow. So the child is not able to walk without support. So we already know what GMFCS the child will be assigned. He needs support. So it is definitely not 1 and 2. It is 3 or 4. Since the child is upright, it is definitely not 5. So between 3, 4 or 5, we need to know the level of support. If the child requires another person in addition to the support in order to walk, then it is level 4. If the child is able to use a support without caregiver person support, then it is level 3. The child's vision is good, the child can hear well, so this will help you in assigning the vision classification system tomorrow. Family members, teachers and examiner understand what he says. That means this will help you to assign level in the communication function classification, this information. Child eats by himself using right hand, but is slow and does not require assistance to finish his meal. This information will be useful when eating ability classification system is covered. Child holds pencil with tripod grip and writes laboriously. You've already been shown what is manual ability classification system. So you know that this is not level 1 and 2. This is level 3. Difficulty with two-hand activities like opening a bottle, make spelling mistakes, does not read simple 3-letter words frequently. So I suspect that there is a comorbidity in terms of learning disability in this child. MRI shows non-specific hyperintensities in the frontal lobe. This might help me understand the axis 4 of the 5-axis diagnosis. So with this history and examination, I now fill this child's idea card. So under body impairment, I write marked spasticity of both lower limbs, and there are some executive function impairment. Based on this function impairment, the activity limitation is child is unable to walk independently, unable to perform activities with both hands. This is the activity limitation. What is the participation restriction? At school, the child is not able to engage in play with peers. That is the participation restriction. Personal, the child has a good, easy temperament and bidirectional interaction. And in environmental, there are positive and committed parents, supportive sibling, but there is a barrier. The child is bullied by schoolmates. Behavioral, we have already understood that the child is very friendly and has bidirectional interaction. That means he's able to look at you directly when you are addressing the child and able to understand what you're trying to say. In comorbidities, remember SPCCBEM. So we found that there is a problem with M, that is musculoskeletal contractures. And in O, that is others, the child has a learning disability. In diagnostic, we found that there was MRI which showed some changes, but there is no genetic test done. In this child, I know for a fact that a genetic test was done much later and he was found to have a genetic mutation in which this kind of spastic CP is seen. So in etiology, most likely based on consanguinity and absence of perinatal risk factors, it is a genetic condition. And in GMFCS, we said that it is level 3 because he is using assistive device and is able to navigate independently. Max 2, the child is able to do without assistive device, but takes a lot of time, and the other classification. So this is how I use the idea card. So with this, we have completed the first step of the idea approach with today's session by discussing ICF, ICF and functional classifications. We have covered the first step of idea approach. Tomorrow, the next 3 steps will be covered, out of which part of this step, that is communication with caregivers, is already done through the lecture of neuroplasticity, but the remaining part will be covered tomorrow. Then you will all be explain how to set goals in the first session itself, goals of intervention, so that the parents are highly motivated based on a successful communication and they come back to you, or at least they are convinced to go to an expert. Then even before they go to another expert, you tell them to at least start some home-based intervention strategies. You will be told tomorrow what are the home-based strategies based on the different functional levels of the child's gross motor and manual ability and other functions. What are the interventions to start? What goals to set to improve the functions? So with this, I conclude today's lecture on part of idea approach. There are no tests for this particular session. I hope you have been able to submit responses for GMFCS, for Max, and I think these were the 2 tests, and for the test on ICF. These were the 3 tests today for you. And those of you who have given, now I invite Dr. Urmila to share the test results so that we can give feedback.
Yes, ma'am, is it visible?
Yes.
Yeah.
Yes. So for the lecture on ICF and daily practice, the first question, 15-month-old preterm. These are the responses. There were total 21 responses, ma'am.
Yes.
Yeah.
Okay. So can I just read 21 responses? And for this question, which says 15 months old preterm child with history of delayed birth cry, not yet sitting, mother's complaint is child's thighs cannot be separated to change nappies. So what component is identifiable here? So some of you, majority have answered correctly, that is body impairment.
Body impairment.
Okay, so the fact that the mother is able to say that the thighs are very tight means there is spasticity, which means body impairment is being referred to with this brief information that is given here. You could also say activity limitation, because we've also given information that the child is not yet sitting. So there is individual activity which is not being done. but there are no personal factors mentioned here and no environmental factors mentioned here. So the correct answers would be body impairment and activity limitation. Can I have the next slide? 9 months old, again 21 responses. 9 months old, second twin, delayed birth cries, Tommy neonatal period, birth weight 800 grams. But what is the problem? Mother says that the child chokes on anything which is given without running through the mixer. That means there is a, which body function is affected? Eating, body function is probably neuromuscular, because there is some problem with the oromotor function, oromotor structure. Which activity is limited? That is eating. And so again here you have a body impairment and activity limitation. There is no participation information given, no environmental factors given. Next slide. 15-month-old, not yet sitting, mother complains, father does not want to take the child to doctor. So this is, again, majority have given environmental factor. Yes, there is a barrier of father not being supportive. There is no activity information given in this scenario. There is no personal factor and no body impair. Activity limitation is given. Yes, not yet sitting is given here. Environmental factor is given, but no body impairment. We don't know why the child is not sitting. Is it because of neuromuscular problem? Is there spasticity or hypotonia? Is it because of some other reason? So we don't know which part of the body function or structure is affected. We know that the activity is affected and the father is not supportive. Next. Is there a next slide? 3.5 years old, again some history here, but mother says child is not able to, what was the full question? Not able to walk. I don't know. I don't remember this question. Child is, was it activity? Not. Majority have responded with participation. Can any participant tell me what was the full question?
It is delayed birth cry and require neonatal.
Yeah, ma'am, I'm reading the full question. 3.5-year-old child had delayed birth cry and required neonatal intensive care management for 45 days after birth. Mother says that the child is not able to walk and not toilet trained. The Anganwadi workers do not like to keep him because of his poor toilet control. Which ICF component can you identify?
So not able to walk is activity limitation. Not toilet trained is also activity limitation. Anganwadi workers are not keeping him in Anganwadi school is participation restriction. Next. So that's it. Okay.
Yeah. For GMFCS, yeah.
Okay.
Yeah. This was the first video.
Yeah. Meenakshi, would you like me to do this?
Yes, ma'am. So just what was the first video level? Correct answer is level 3.
That was Aditya.
Yes, ma'am. Level 3 child was
Hamsa is
walking
there.
with frame.
Hamsa is there. Hamsa is there.
Carry on. Carry on.
Yeah,
So
carry on.
Great.
Yeah, the child was walking with frame within the house that was on even surface. It was level 3.
Yeah.
Next slide.
85%. 85% have answered it.
Yes. So second video was child was walking on a level surface with impaired balance, and there was visible difficulty for the child to walk on even surface also. So yes, it was level 2. 51% have answered correctly. So third video was the child was walking with walker when the father was supporting from behind.
It was level 4. 66% have answered level 4 correctly. Fourth one was child climbing up and down the stairs without railing support. It is level 1. 85% have answered it correctly.
Wonderful. Wonderful.
Fifth one, child was sitting when the parents were supporting at the neck and trunk. It was also using
orthotics.
Hip surgery. Yes, ma'am. Orthotics was being used, and it is level 5. 88% have answered correctly.
So I would like to congratulate the participants as well as the speaker for such a wonderful lecture. Next slide. Max, ma'am, you'll have to take this. I think Vimochana is not there.
Okay. Which was the first
Answers,
question?
yeah.
Priyanka is there. Priyanka is there.
And I've written the answers, ma'am. Correct answers I've mentioned
Okay,
here.
Urmila, you continue then.
Yeah. For the video 1, the correct answer is level 2. The child who was eating on a with a spoons.
No,
and
I think the first video should be level 1. I remember the child was eating well, comfortably with the spoon, taking the upma she was eating. So level 1 is correct. And everybody's answered level 1. Can we have the next video, next answer?
Yeah.
What was the next video?
This is video 2.
Priyanka is not there. Yeah.
Priyanka, do you remember what this video is?
I don't remember. Third one is the child.
Ma'am.
Yeah, I think. Yeah.
Priyanka. The child was coloring.
Child coloring, yes.
So
with effort. Yeah.
So that has to be, ma'am, level 2, isn't it?
Yeah, absolutely. With little effort. That's it. Yeah.
Correct. So if majority have answered it correctly, yes. Next is video 3. Yeah. Video 3 was
the boy playing that this thing, putting the rings.
No, that was, I think, video 4. Was it? Does the participant remember which was video 3?
Ma'am, the same one, the boy putting the rings in the rods. The video 4 was not video, actually, it was a picture.
Picture. That's right.
Okay. So video 3, the child, ma'am, you would like to comment how the mother was holding the child?
Yeah, the mother was supporting the child, and the child needed support at the ankle. I mean, I'm sorry. Yeah, at the wrist. So that is level 3 with support.
So people have answered correctly, level 3, yes.
And level 4 was a computer picture.
So fourth picture was the picture with a video.
Computer, yeah. It was a picture.
Majority have answered level 5. The child required help at every joint before the child could even manipulate. So a lot of adaptations were required for the child, right?
Yeah.
Okay, so this was also, I think, well understood by the participants. So this was great.
Yeah.
I hope everybody benefited from the different aspects of neurodevelopmental assessment, history, and evaluation that we have covered. And please go back and read through your manuals to further clarify your doubts. Tomorrow, come back sharp at 9. We will do the remaining sessions.
Yeah. Ma'am, I have this announcement regarding idea card, ma'am, home assignment.
Yeah.
So I have already shared the idea card in the WhatsApp group, and I'll be dividing the participants into groups, and I'll be sharing the questions to each group by 7 o'clock today, and every group has to refer to the question and fill up the idea card, and one of the group member will have to present the idea card during one of the sessions tomorrow.
Yeah.
Okay, so this idea card, you are going to they have to fill only the first part, not the second part, isn't it?
Yeah, yeah.
Yes, ma'am.
And in the functional classification section, they have to fill only GMFCS and MAX.
Max.
So a case scenario will be given to both the groups, and they have to make their own WhatsApp group and discuss the different components of the idea card, choose the right answers from the case scenario and fill it, and one group leader will present it from one group and the other from the other group.
Yeah.
So I hope all the participants are agreeable to this exercise. And tomorrow at 9 o'clock, we will begin with your presentations and then go on to the rest of. So 15 months. So this is a very important question Kirti is asking. 15 months age and preterm born, is it not a personal factor? So I see this is past history. Okay, so baby born at 15 months, currently the baby may have been 3 or 4 years. So the personal factor will be the factor age at which you are going to initiate interventions. That would be a personal factor. 15 months, sorry, this baby's age was 15 months. So yes, that will come under personal factor. But preterm born will be not a personal factor. It will be a risk factor to identify the possible etiology.
Yeah, yeah. Meenakshi, another clarification we need to do. Kindly remember the functional classification levels are applicable only to cerebral palsy. They are validated only to cerebral palsy, but the rest of the things can be applied to all other neurodevelopmental disorders, including the idea card. Okay.
Thank you very much, ma'am.
Yeah.
So tomorrow, everyone, please be very punctual so that we can let you enjoy the rest of the Sunday, finish on time, and you all can gainfully learn a lot of things. Thank you so much. With permission from Shashikala ma'am and Dr. Urmila, we can leave this.
Okay, you're permitted.
Thank you.
Permitted,
Bye-bye.
Bye. Bye to everybody.